Welcome to the webinar series of the Indian Rheumatology Association. And today we are going to have a chapter on vasculitis. Uh, Vasculitis and related diseases were not really well known beyond the boundaries of the big institutions and medical college before 2000. Professor Paul Bacon, who came in 1997 to India to attend our IRACON, talked to us about doing something in this, particularly Takashi arthritis. So the IRAWAS group, our Indian Rheumatology Association Vasculitis Core Group, was born, which was in 2000. Professor Ramnath Mishra, Debashish Danda, Alakendu Ghosh, Pradeep Bambari, Rajeshwari, Yojana, Binay Pal, Rohini Samant, Krishnamurthy, Shivakumar, Lisa, Abel Lawrence, Vikas, Rajiv Gupta, and many others initially were the part of this group. It underwent many transparency changes and transformations. New people came, old people left, but the group continued. Later, Aman Sharma, Ramesh Jois, John, Ritika Goel, and others joined. Persistent effort by Ramnath Mishra, Debashish Danda, Alakendu, and others kept the group going to produce some significant papers as well as posters, which were published as a disease and related diseases of vasculitis and vasculitides, which were unknown, have become quite common in last 2 decades, thanks to the efforts of these people. And IRAWAS as a group is still continuing and made significant progress. Today we have a very bright, I won't say he's very young, but one of the star of the Indian Rheumatology Association, Dr. Raj Kirandudam from Hyderabad. He is quite well known to everybody and is doing a very good work, though he's in private field. His academic interests are very well known and he's very knowledgeable, and he's going to talk on PAN today. Probably only the recent entries to the Indian Rheumatology Association would not know much about Raj Kiran. Raj Kiran is based in Hyderabad. He's a member of the Indian Rheumatology Association, member of the American College of Rheumatology at ULA. He has made a significant contribution. He did his MBBS from Kakatiya Medical College in Warangal, MD, General Medicine from Gandhi Medical College, and Fellowship in Rheumatology from Nizam's Institute. I think he has established himself with a good name. He is the rheumatologist of all the Telugu stars, Tollywood stars, and we all know. And I think he's going to do a very good job. And I also welcome Yojana Gokhale from Mumbai, who everybody knows Yojana. Yojana was one of the initiators when we started the vasculitis core group, along with Paul Bacon, Ramnath Mishra, Debashish, and others. So Yojana will be moderating with me. We can start, Raj Kiran.
Good evening, everyone. Thank you, Mahendranath sir, for this kind introduction. I am going to talk on Polyarteritis nodosa today, and I thank Sapan sir, Shenoy, Alkhindu sir, and entire fraternity of IRA for giving me this opportunity to talk about Polyarteritis nodosa in this IRA web series. Thank you very much once again. So I'm going to start. Polyarteritis nodosa is a rare form of primary vasculitis. This is very heterogeneous in its presentation. So as the treatments which we have to decide, and so as the disease course of polyarteritis nodosa. Now, in next 15 minutes, I'm going to talk about the historic perspective, systemic pan, cutaneous pan, monogenic pan, and infection-associated pan. So what I understood and what I want most of our audiences to know is pan can occur at any age. So Kusumal and Mayer, they have first written a case report in German Archives of Medicine, where they have presented and written a case report of a 27-year-old young man who came with fever, severe body pains, tachycardia, and mononeuritis multiplex and pain abdomen. So looking at him, Mayer said, I can give his prognosis before giving his diagnosis. He's very bad. So we can't do much at this point of time. He said it to Kusumal, and they have done an autopsy after his demise. This man, within the period of maybe 3 or 4 weeks, he died. Nothing much could not be done. And in autopsy, they have found a lot of these nodules along the medium-sized vessels. They said the vessels were almost the size of the arteries of the liver, and they termed it as a periarteritis nodosa. And over last 1.5 century, the pan has gone through a lot of things. I think this is one of the disease which has been like divided into so many other diseases, or it has evolved in, it has gone into so many other diseases. In 1936, each disease was segregated from pan till almost like nearly 7 decades. All diseases of vasculitis were labeled as periarteritis nodosa or polyarteritis nodosa. In 1936, GPA got separated. Then later on, ANCAs have been described in 1980s, and separate entities like ANCA-associated vasculitis have been described. And in Chapel Hill consensus conferences, they have completely separated pan, making it as an arteritis or a necrotizing vasculitis, which is restricted to medium and small sized vessels, and they have separated MPA from it. And more specific form of vasculitis and its nomenclatures have been described. And in 2000s, like after the discovery of MEF1 gene, the FMF associated pan has been described in Turkish group and Eastern Mediterranean groups. And then in 2021, a Chapel Hill consensus conference has given more detailed nomenclature separating pan from other type of diseases. And in most recently in 2014, DADA 2 has been described. So in 1990s, ACR has come up with this criteria, and which has the clinical features in it, and which has the radiological features in the form of an arteriographic abnormalities and a biopsy to prove necrotizing vasculitis. So like most of the case reports and case series which have took ACR 1990 criteria and which have presented their cases have either a positive arteriogram, or they have a biopsy which is positive with a negative arteriogram, or most of the patient had a presentation with a neuropathy and weight loss with negative arteriogram and arterial biopsy. As I said, in 2021, the nomenclature has come out saying that polyarteritis nodosa or a classical pan is the disease which has to be restricted to medium-sized and small arteries. And since the case report of Kusumal, it has been observed by many people that if a pan is untreated, the death rate is quite high. And if you diagnose it early and treat, many people can survive. So the Indian experience has been written by Professor Rohini Anda in 2015, and the data has been collected from various search engines. Very small number of cases have been collected and presented. AIMS had 17 cases. Most of them are HbSAg negative. Subsequently, next 5 to 10 years of their collection, they had patients with HbSAg positive. Chandigarh had 24 cases. The unique thing in Chandigarh data is they have noticed that 2 or 3 patients had APS along with polyarteritis nodosa, and they presented with Budd-Chiari syndrome kind of presentation. And Vellore, Chandigarh data has come, which have looked into. They had a lot of case reports which had talked about the renal hemorrhage and the renal infarcts and the shrunken kidneys in patients with polyarteritis nodosa. The series from Chennai and Mumbai were also there. And from Eastern India, Dr. Mandal et al., they have presented a case series of nearly 30 patients of pediatric polyarteritis nodosa. In 2015, Dr. Handa criticized, saying that there are a lot of challenges for vasculitis in India. There is no registry, there are no long-term studies, the collaboration work is not going on, pathologists may not be aware of PAN. So these are a lot of challenges in India. We are unable to diagnose vasculitis or treat vasculitis because we are unable to pick it up. But it's 2021. So in the last 6 years, what had happened? We have a wonderful and one of the best institutions in the world. I can proudly say to any of my colleagues across the globe, and most of the institutions are looking collecting the data, like they are maintaining the registries. And we have a vasculitis interest groups which have been developed in last 6 years in various ARACONs, which are doing collaborative research work, and IRA state chapters, and most of the rheumatologists by themselves are educating physicians. And there has been a lot of accessible imaging facilities which have been developed in 2-tier cities. So it's 2021, and in another 1 or 2 years, I expect much more data coming from India. especially from most of the government institutions as well as private institutions. This data, which is published in 2015 from Aman Sharma sir group, they had collected data for almost 10 years, and most of them are more than 18 years of age, and 25% of the patients were having hepatitis B, and they have noticed that overall mortality is around 11%, and there is no mortality difference between hepatitis B pan and non-HBV pan. And they have said like majority of their patients, 80% of the patients had peripheral nervous system involvement in the form of mononeuritis multiplexa or sensory motor axonal neuropathy. And fever and weight loss were observed in 50 to 70% of the cases. When you compare Indian data with France data, which has a large numbers of around 340, and Korean data and previous Indian data from All India Institute, if you see, the age is slightly higher in France group and the Korean group compared to Indian group, which we had almost a decade less. And most of the patients had neurological problems and fever and weight loss, which are very similar to the Western group. And there are different subgroups of polyarteritis nodosa, or whether they are subphenotypes or distinct diseases, we really don't know as on today. But PAN can be looked into these four angles. We have a classical polyarteritis nodosa, we have a localized PAN, PAN restricted to skin or PAN restricted to certain organs like testes or gastrointestinal system. We have an infection-associated PAN, and we have a monogenic PAN. So what is common in all these group of diseases? The common is necrotizing vasculitis. I'm not going to talk on much of histopathology. Ritambra might be talking next. So I can just tell you that most of these subsets, they have necrotizing vasculitis in their histopathology as a common factor. And what is polyarteritis nodosa doing, and how does it develop? There can be an environmental trigger in the form of infection. And if the patient is genetically predisposed to have an increased immune response, or who can develop an anti-endothelial cell antibodies or increased TNF or increased cytokines like interferons and interleukin-1s. So these are the patients who can get predisposed to develop polyarteritis nodosa. The hallmark of polyarteritis nodosa is focal segmental necrotizing leukocytoclastic vasculitis in medium and small sized arteries. And patients develop these fevers because of this hyperinflammation kind of state, and the basal metabolism rate is increased, and they develop weight loss and malaise arthralgias. And there is an inflammation of arteries. Sometimes occlusion of arteries can happen because of neutrophilic inflammation, complement activation, thrombosis, like activation of coagulation cascade. All these things might lead into blockade, and they can cause ischemic features like mononeuritis multiplexa, gastrointestinal ischemia, testicular pain due to ischemia of testicular artery, and renal artery ischemia can lead into malignant hypertension. And there can be, once the destroyed vessels, can cause aneurysms. And I had an experience of treating an 8-year-old child who presented with an internal nuclear ophthalmoplegia, hypertension, right hemiparesis, and I had an IC bleed. This was a very peculiar case. When I discussed this with Dr. Aman Sharma sir in 2016, he said, Raj, this looks like a childhood pan. You go and image visceral arteries. And when I came back from EC meeting, and when I did a visceral imaging, surprisingly, I found these aneurysms in mesenteric leg arteries and renal arteries. So then we sent a CEC1 gene, the CEC1 gene mutation was observed, and ADE2 levels were low, and started treating this patient on anti-TNF. This case report has been presented by Ashok Kumar sir, which had a 24-year-old man who presented with pain abdomen, digital gangrene, and he has this problem since the age of 8 years, recurrent skin lesions, pain abdomen, testicular pain, fevers, and the imaging shows aneurysms in the visceral arteries and renal arteries. This patient has been treated with cyclophosphamide, but unfortunately he developed a cerebellar abscess after treating with immunosuppression, and he passed away. And this is the case, this is a unique case of a 42-year-old man who presented with 4-week history of fever, myalgias, inflammatory markers were elevated, but CPK was normal, and MRI is showing a muscle edema involving anterior and adductor compartment of muscles bilaterally with intermuscular edema. And the biopsy of this particular area, when it has been done, it is showing fibrinoid necrosis with neutrophilic leukocytosis, giving it a diagnosis of polyarteritis nodosa isolated to muscles. We have different presentations of cutaneous polyarteritis nodosa, like patients can present it with a livedo reticularis kind of thing, ulcers, nodules, various presentations are described of cutaneous pan. We need a deep biopsy, like which includes medium-sized arteries to demonstrate polyarteritis nodosa. This is a series of cases which has been presented by Anand Malivasar in 2006 IJR. Coming to cutaneous pan, it's said that it's more common in children, and the relapses are often associated with streptococcal infections. And we need to look for drugs if the patient is taking drug like minocycline or IBD. Extracutaneous manifestations like neuropathy or myalgia are associated only to the adjacent areas. And very few people progress to systemic pan. Japanese group, they have noticed that the myosin mRNA levels are higher in skin biopsies of the patient who had a systemic pan rather than the patients who had a cutaneous pan. The relapses are quite frequent, but it's not severe. It can be treated with drugs like glucocorticoids, colchicine, and dapsone. Single organ vasculitis, sometimes it can be diagnosed when on the surgical biopsies. Testis has been found to be most common organ which had polyarteritis nodosa in the histopathology when it has been removed surgically. And we have non-systemic vasculitic neuropathy, which is less severe than systemic vasculitic neuropathy. In the patients, this kind of patients can present only with sensory motor neuropathy or mononeuritis multiplexa. When we do a biopsy, we find there is a vasculitis. Lab markers are not specific, and diagnosis purely depends on biopsy. Certain drugs like minocycline, anti-TNF, sulfasalazine can cause pan-like picture. Hepatitis B and HIV and HCV are associated with polyarteritis nodosa kind of presentation. HBV patients who have pan-like condition can have higher disease activity, very low relapse risk once they are treated very well. And microaneurysms in this group specifically are seen more in mesenteric vessels than in renal arteries. We have a case series from Mumbai in 2002, in which they have said that the patients among 180 patients, there are only 6 patients who had a pan who have hepatitis B. The immunological process which is responsible for pan is typically observed within 6 months of hepatitis B infection. Glucocorticoids, plasma exchange, and antivirals are used to treat this disease. Plasma exchanges can be stopped once seroconversion is achieved, as HBV-associated pan rarely relapses after seroconversion. So the virus can directly attack and cause the vasculitis, or the immune complexes can cause vasculitis. So cutaneous manifestations are more commonly seen with HCV pan. These patients do not have cryoglobulins, and the HCV related pan, the reported duration of viral infection can last up to 20 years. And HIV related pan is most frequent cause of vasculitis in HIV patients. HBV pan is more severe, but once treated, it do not relapse. HIV pan is mildest form. HCV pan is mild form, but it frequently relapses. Coming to monogenic diseases, FMF, familial Mediterranean fever, is associated with polyarteritis nodosa type of presentation. But again, as I said, the incidence of polyarteritis nodosa is significantly reduced because of hepatitis B vaccination available, and the cases of hepatitis B has been reduced. And similarly for FMF, better treatments are available, colchicine usage has been increased, and anti-IL-1 treatments were available. The most important feature of this FMF is the cases of FMF can have perirenal hematoma as a distinct feature, and it is seen nearly 50% patients. Any child presenting with recurrent fevers, pain abdomen, and if we look at a perirenal hematoma, we need to suspect polyarteritis nodosa in this group. Coming to DADA2, it's an autosomal recessive disease. There is a loss of function of CECR1 gene, and there is a deficiency for ADA2. ADA2 is a growth factor for leukocytes, and in presence of ADA2 deficiency, most of the macrophages, they get differentiated into more pro-inflammatory M1 macrophages rather than M2 macrophages. So this leads into vasculitis type of presentation. Most of the cases, they present with early onset polyarteritis, hemorrhagic and ischemic strokes, and there can be immunodeficiencies along with them. The histopathology is indistinguishable from classical pan, and we need to consider DADA2 in a child who is presenting with livedo reticularis and there is a history of stroke, and if acute phase reactants are elevated, and if we identify necrotizing vasculitis in histopathology. And this is an example of collaborative research. I thank Professor Aman Sharma sir for involving me. And here we have collected nearly 33 cases of DADA2 across India. Many like researchers across India have got involved and contributed their cases. In this, like compared to other groups, it has been noted the mean age is slightly higher. 23 years was the mean age, and like across right from infant to 51 years, like patients had been diagnosed with DADA2. Most common presentations were CNS involving strokes, and the acute phase reactants were got elevated. And there are other monogenic diseases like sting, where the interferons get elevated because it encodes this. There is a mutation which encodes the stimulator of interferon genes, protein sting, and it gets mutated, and there is a higher levels of interferon. This defect results in uncontrolled stimulation of sting pathway, and this will cause an endothelial dysfunction and inflammation, and they can present with vasculitis and interstitial fibrosis. There are also mutations involving RAG1, RAG2, which can cause polyarteritis nodosa kind of a presentation. So to conclude, like how to diagnose PAN. PAN does not affect lungs and do not cause glomerulonephritis. This needs to be remembered. This needs to be remembered when you are diagnosing PAN. So most of the case reports, they have said that they have not observed lung involvement, and glomerulonephritis, the smaller vessels are not involved. So we need to have a clinical suspicion, and we can make the diagnosis by angiography, and the biopsy findings can the typical necrotizing vasculitis, fibrinoid necrosis. If you identify it, we can make a diagnosis of PAN. The arteriographic lesions are very typical. We have a saccular or a fusiform microaneurysm, in the form of a rosary beads. And these are predominantly observed in mesenteric renal or hepatic arteries. However, the gold standard for the diagnosis is demonstration of focal, segmental, pan-neural necrotizing inflammation of medium-sized small arteries. The inflammation is across the vessel, involving intima media and adventitia. So a lot of biopsy sites can be taken. The skin is most easy to access. Surreal nerve biopsies, superficial peroneal nerve, and radial nerve biopsies can be taken. The yield from muscle biopsy is slightly lesser compared to others. ANCA is typically negative. So we need to keep all these things in mind when you diagnose PAN. So we have this classical PAN or cutaneous PAN. Coming to treatment, glucocorticoids and cyclophosphamide are choice for classic PAN if it involves the major organs. For cutaneous PAN, most of it can be treated with, as I mentioned, glucocorticoids and milder drugs like dapsone, azathioprine, or methotrexate or colchicine. For classical PAN, we might have to give cyclophosphamide, and the resistant cases of cyclophosphamide have been treated with rituximab. HBV associated PAN, the treatment is glucocorticoids, plasma exchange, and antiviral treatment. And FMF associated vasculitis, it is glucocorticoids, like colchicine and anti-IL-1 therapies. The other drugs like DADA2, they are resistant and refractory to treatment with steroids and cyclophosphamide, and most of them might respond to anti-TNF therapies. So my final slide, can we predict relapse in PAN? So a lot of things have been looked into, how to predict relapse in PAN. And by now it's very clear that HBV associated PAN might not relapse, and cutaneous PAN will have relapses, but they are milder form. And most of the polyarteritis nodosa, if properly treated with an adequate immunosuppression, they're difficult to treat, difficult to diagnose, but once treated, the relapse rates might be low. But however, if the patients had a BIVAS score of more than 13.5, these are the patients group which have a higher risk of relapse. And if the patient had a 5-factor score of more than 1, they have a higher risk of relapses. With this, I thank you, ladies and gentlemen, for your patient hearing. Thank you, Ira, once again for giving me this opportunity.
Thank you, Rajkiran, for the brilliant exposition of PAN. Can we take some questions now?
Harish is asking, like, how would
Yes.
we know about perirenal hematoma in a child suspected to have FMF PAN? Do we do aspiration? Honestly, I'm not very sure. I really don't know. But I think we have, we generally do an ultrasound. A good radiologist can tell a possibility of perirenal hematoma, then CT abdomen or MRI abdomen may tell us about perirenal hematoma. And I depend on my radiologist and nephrologist. And if we are thinking about perirenal hematoma, I think we need to discuss with our other colleagues, and we want to confirm. And in a child with a background history suggestive of FMF, I think you can do further evaluation for FMF.
For CNS aneurysms and PAN, Raj, you want to comment on that?
Yeah. CNS aneurysms in PAN, yes, I think cases of DADA2 had described CNS aneurysms, and the cases they had intracranial hemorrhage. I think 5 or 6 cases of DADA2, which like we have presented, which we have published last year, had intracranial aneurysms, which had led into bleeding. But I think in adult pan it is not that common as visceral aneurysms.
Maybe one more regarding preference for cyclophosphamide in childhood pan versus UVAS versus monthly cyclophosphamide.
Yeah, I think childhood pan, like when I was discussing with Aman sir, who was treating a lot of these cases, and even my little experience of treating around 6 patients of childhood pan, I think whenever we see a childhood pan, we always try to rule out these monogenic diseases. We try to look for the markers of DADA2 or FMF or any other SAVI or any other things, and based upon that we can treat. We can identify, because if it is DADA2, we need to prepare ourselves. Some people have tried cyclophosphamide, but most of the cases they're resistant to cyclophosphamide, which needed to be treated with anti-TNF drugs. I think like if nothing is there, just only it's a childhood pan, like which is a systemic pan, we can treat with cyclophosphamide. Otherwise, most of the childhood pan, like the literature, whatever I was going through, and the cases which I have seen were presenting only with cutaneous polyarteritis nodosa. And for cutaneous polyarteritis nodosa, I think simple drugs like a course of steroids, NSAIDs, and azathioprine or colchicine might help. We might not need to go up to the level of cyclophosphamide. I think childhood pan is a broad categorization. We need to see whether it is a monogenic or a cutaneous or a systemic. Coming to UVAS and monthly cycle, I think most of us treat polyarteritis nodosa with 15 milligram per kg body weight of cyclophosphamide, initially 3 doses every 2 weeks, then later on every 4 weeks. So this is how even in my practice, the initial treatment goes with the Revasc protocol, what we have, like 15 milligram per kg body weight, the first 3 doses every 2 weeks.
There is a last question from Praveen Jain, Raj. How common is cerebral arteritis aneurysm in PAN?
In adult pan, I think it's less commoner than visceral artery aneurysm, sir.
Okay. I think I don't see any more questions. We can proceed to the next.
Dr. Netra, madam, I think you can take over the next. She is, madam is professor in the Department of Histopathology, PGI Chandigarh. Been a faculty for 24 years with an interest in renal transplant pathology and especially GIT. Has been the vice president of ISRTP, and she received various awards, including the Nolkar Award for IAPM for published work, and many other awards. Has been in administrative functions as well, and has taken care of a lot of international assignments. Madam, I welcome you for the talk on pathology of different vasculitis. Thank you, ma'am.
We also have a very long association, Sapan, with Ritambara. She has been participating in our IRA conferences, and a lot of case studies she has presented, if you remember.
Thank you, sir. I know I love this association, and I shall, I think, continue to be part of this association if permitted. And I present my special thanks for today's evening. And what I'm going to do is present how we approach the material sent by our rheumatology colleagues, and how do we go about its interpretation. So as we know that tissue sent to us is generally kidneys in cases of RPRF, skin biopsies for palpable purpuras, nerve biopsies for mononeuritis, maybe nasal or nasopharyngeal biopsies when you have nasal crusting, temporal arteries for tender temporal arteries, and sometimes even aneurysms. GI we generally get from surgeons, which come as either gangrenous bowel or strictures when they operate from. It hardly comes from rheumatology per se. And lung nodules, sometimes when they don't resolve by various treatments, then that's the stage when we get these lung nodules as a biopsy or from there. So we all are aware of this Chapel Hill nomenclature, but how do we really practically go about it? Like, as we know, we have classified these vasculitis into different categories based on the size, and there is a mechanism of immune mediation in some areas, and in some categories we need a serology with that. So how do, as a pathologist, we integrate all this information to help come to the diagnosis in these particular cases. So what we, in addition to biopsy material which we receive, we also take into account the serology, the immunofluorescence tissue if available, and sometimes we take help of immunohistochemistry. So we all must have seen this diagram multiple times. As you know that this component which is in green is interpretation of these entities in addition to biopsy also requires presence interpretation of immunofluorescence on the kidney tissue. Not only this, even if I want to diagnose a medium vasculitis in a setting of rheumatological conditions like lupus or rheumatoid arthritis, immunofluorescence would be required here also. Though in classical medium vessel vasculitis like PAN and Kawasaki disease, we don't need immunofluorescence. I think maybe needed in Kawasaki disease. Large vessel arteritis, large vessel arteritis like Takashi GCA and now IgG4. So we do need IHC in this particular case. So it's not only the biopsy, we have to use our ancillary test too for the interpretation. And another point, when we come to the diagnosis of any particular size vasculitis, uh, it is equally important that it's not the only size of the artery which matters, because even a small vessel vasculitis can involve medium-sized vessels as well as even larger arteries we have seen at autopsies. So is the case with Takayasu arteritis. We have seen evidence of capillaritis in lungs at some autopsy series. So it's only the dominant vessel involvement in that particular case which determines, along with serology, that which category it belongs to. Generally, when we label them as these kind of vasculitis, small vessel we mean when we are talking of intraparenchymal vessels, which are within the parenchyma. Medium vessels are the visceral branches, the initial branches, and larger arteries are these, the aorta. So, but as you all are aware, when we diagnose polyarteritis nodosa in a nerve biopsy, I'm not looking at a visceral artery. What I'm looking at a smaller branch of an artery. So that is why I'm trying to emphasize that a medium-sized arteritis can also involve smaller branches, like branches which supply the nerve bundles. So it's overall the serology taken in context of the clinical scenario that helps us come to the diagnosis. So let's just take, for example, we start with the renal pathology. So in a small vessel vasculitis, what all can happen? Within the glomerulus, depending upon whether it's an immune complex mediated lesion like this group of conditions, what I generally see is a proliferation. But if there is ANCA-associated small vessel vasculitis, these three categories, what I see is either a normal glomerulus or I see necrosis or crescents, though crescents can be seen along with proliferation also. But this small vessel vasculitis can also involve medium vessel. In that case, in kidney, I might have an evidence of infarction, which later on may be seen as an atrophy. So what I mean to say is, though the different compartments of each organ may give us hint, and there could be a different type of pathology present, even with the same small vessel vasculitis and so on. So just before I come to the pictures of specific arteritis, I thought let me just show what the normal looks like, because that becomes important. So normal glomerulus is like this. These capillaries are empty, and this is the Bowman space, which is also going to be empty. Any proliferation here is, I'm going to call that crescent, and any proliferation cells within these capillaries, I'm going to call endocapillary proliferation. An artery should be normally like this. This would be the endothelium, internal elastic lamina, and a layer of smooth muscle, normal tubules. So now we shall see some abnormalities. So in these vasculitis, especially the small vessel vasculitis or immune mediated vasculitis, we will see necrosis, which can heal in the form of fibrosis. This necrosis, if involves the peripheral, if peripheral these capillaries, they may result in release of these formation of crescents, which are these extra capillary proliferation seen in the Bowman space, and which may again, if it is devastating, it may rupture the Bowman's capsule. Earlier, we used to call crescent when it involved 1/3 of the circumference. The nomenclature has been changed to 25% of the circumference having more than 3 layers. And in lupus, even up to 10% is if 10% of the circumference is involved, we take it as lupus being as a crescent. Crescentic will label when more than 50% of the glomeruli in that biopsy shows as crescent. So all these terminologies I shall take into account when I'm describing some of the cases. Similarly, the crescents, when they have more than 80% cells, it's a cellular crescent. If it has more than 80% matrix, it is a fibrous crescent. If it is anything in between, it's a fibrocellular crescent. Age of the crescent helps us in kind of subcategorizing our crescentic genes, as I shall show. So let's take 2 examples. One is an elderly male which comes with hemoptysis and cough. On examination, he was found to have some active sediments in the urine. He had some abnormalities in the chest, which I shall show you later on. Another female who comes with RPRF, raised creatinine, and she had some nephrotic red proteinuria. ANCAs we shall talk later about. So in first case, I see my kidney biopsy. Most of the glomeruli are not normal. They have this kind of crescents. These crescents with underlying tuft being normal. So both these things give me a clue. And when I'm looking at the crescents, some of the crescents are fibrous and some are cellular. So that means they are of different age. Some of the crescents have a periglomerular, this kind of granulomatous reaction, and there are these kind of reaction around it, and at places sometimes there was occasional interstitial granuloma away from the glomerulus. Occasional artery showed this kind of fibrinoid necrosis with neutrophilic debris. That means there is arteritis also, another arteritis in the same biopsy. When I did immunofluorescence, all the glomeruli were negative. So what do I have? I have crescents of different ages. There's no endocapillary proliferation, but only necrosis, vasculitis in the biopsy, and interstitial granulomas. So all these features suggest to me, and presence of granulomatous glomerulitis was there. So all these features suggest to me that this is a crescentic GN, which is post-immune because IF was negative. And since there were interstitial granulomas, I would favor a granulomatous polyangiitis, and I would like to look for presence of C-ANCA in general. So after making a diagnosis of post-immune crescentic GN, we look at the reports for C-ANCA or P-ANCA. Though histology of these two do not differ significantly, and there are no clues on morphology to suggest whether it's going to be C-ANCA or a P-ANCA positive case. Similarly, even ANCA negative crescentic GN have not been found to be different on morphology. Now, these ANCAs, as you know, can be P or C ANCA, and it has been shown that in our population, P ANCA is more common, and it sometimes tends to be more non-specific also because it may be associated with many other infective conditions also. Now, if we have to look at what are the associations with the different kinds of these vasculitis, that is GPA, microscopic polyangiitis, or EGPA, C-ANCA is most often associated with GPA, though it's not right to say that others cannot be associated, and there could be a percentage, 5%, which may be negative also. Whereas MPA and EGPA, almost 50% may have P-ANCA. So these are the figures in collective, but in one case, it may be difficult to say. About 70% of post-immune GN may be renal limited, or there may not be any evidence of systemic vasculitis. Though 75% of the 70% of the patients who have this MPO, who have this post-immune crescentic GN, they have some sort of systemic vasculitis. When we see the biopsy, the cases which are of post-immune category generally tends to be crescentic in 90% of the cases, whereas ones which are anti-GBM will only be crescentic, that means more than 75% crescent in 25%, and even immune-mediated disease would have a crescentic presentation in about 20% cases. And there could be an overlap of these serologies, which may modify the presentation also. Presence of an anti-GBM with these MP or PR ANCA modifies the morphology in the form of, I'll show you how it differs from a simple case of anti-GBM. Another point, whenever we report a post-immune GN, after that we also try to give a burden classification, which classifies the biopsy based on number of cellular crescents and number of sclerotic crescents, or ones which are having only focal necrotizing lesions. So this is the classification which we generally apply, which means if they are less than 50% of the glomeruli show necrosis, it's a focal class. If more than 50% have crescent, it's a crescentic. And if more than 50% have sclerotic lesions, it's labeled as fibrotic lesion. And it has an implication because ones which are focal tends to have a better survival as compared to ones which are sclerotic. Their responses are different. So now coming to case number second. So second case had an RPRF presentation, and as you see here, here the crescents were largely of the same age, and this is the underlying tuft. This crescent is very cellular, underlying tuft is hardly visible. There is vasculitis only in the afferent region. There is an evidence of granulomatous perivascular inflammation here also. All the crescents, as you see in this biopsy, are of same age. So when I see crescents of the same age, underlying tuft being normal or necrosis, then on biopsy itself, I start thinking for a anti-GBM disease. And when I come to immunofluorescence, I see this kind of linear staining with IgG, C3, and maybe kappa and lambda. So the age of the crescents and absence of vasculitis or granulomas in the interstitium does help me kind of make up my mind that this is likely to be an anti-GBM disease. So here there was crescents of the same age, no endocapillary proliferation, because endocapillary proliferation would occur in immune-mediated disease. Necrosis was not present, though it can be present. Absence of interstitial granulomas and vasculitis in the biopsy does indicate on morphology itself that it's going to be a anti-GBM disease. So this is the algorithm we follow when we get a kidney biopsy, whether it's going to be a post-immune GN or anti-GBM. So age of the crescent matters, interstitial granulomas matters, and vasculitis matters, but ultimately it will be the immunofluorescence which will decide. If the underlying tuft shows me proliferation, then I'm going to think of either immune-mediated disease or C3 disease. Then depending upon what is the underlying immunofluorescence, I will further classify. So I will say crescentic. If it is a full house pattern, I'll say it's a lupus nephritis. If there are IgM dominant deposits, it will suggest me a cryoglobulinemic crescentic. Then I will look at the EM also. IgA dominant immunofluorescence would suggest that it is a crescentic of IgA variety. So these ANCA-associated vasculitis, though generally when we are talking of glomeruli, we are talking of capillaritis, but it can involve medullary arteries or vasa recta, so there could be medullary angiitis, and even a intraparenchymal, what we call intralobular vessels within the parenchyma may also show us fibrinoid necrosis and this debris. So that means different range of arteries can be seen within the biopsy, which can show us arteritis. So whenever we have this kind of a crescentic GN, it's not only the morphology, we also take into account the serology, which becomes important to classify our GN. And on biopsy, we have to have immunofluorescence to further classify our crescentic GNs. After having made our diagnosis of post-immune GN, along with taking into account serology, other clinical parameters also are taken into account. Like if there is a granulomatous inflammation in a post-immune GN, Eosinophils may be there or may not be there, but if the patient has asthma or eosinophilia, it goes into the category of EGPA. If patient doesn't have asthma but has this kind of the kind of case I showed, granulomatous crescentic GN, in a patient with generally C ANCA, maybe sometimes P ANCA positive, then that is likely to be labeled as GPA. In case there are no granulomas, no asthmatic history, then it is likely to be a microscopic polyangiitis. Extraglomerular, there could be a renal limited post-immune GN as well. So in a systemic post-immune GN, in a post-immune GN with a systemic presentation, we have to look at the other system involvement and different peripheral blood picture, as well as ANCA serologies, along with clinical history and other organ involvement. So in case of EGPA, the granulomas may have this kind of excess of eosinophils. There could be presence of vasculitis. Very commonly involve gut and small intestine, GIT and skin biopsies are also one of the common sites of involvement. And this is from one of the case where there was presence of this paniculitis, where deeper down we have had an artery which is showing us vasculitis. There were these kind of collections here which were eosinophil rich, and an artery which had this kind of eosinophilic granulomatous inflammation, which showed break in internal elastic lamina. So this patient, along with history of asthma, was labeled to have a presence of EGPA, because there were excess of eosinophils, granulomatous necrotizing vasculitis in the paniculitis part of the skin biopsy, and skin biopsy was negative on immunofluorescence except for fibrinogen. So what I'm trying to say is that different tissues provided to us and different tissue reactions do help us in deciding the type of vasculitis. Many other organs can be involved. Lungs can be involved. There can be granulomas in different organs, depending, or vasculitis in different organs. Lungs are one of the important sites because renopulmonary syndromes are generally seen with MPA, with GPA and anti-GBM. Pan and medium-sized vasculitis do not generally show involvement of lungs. So like this is these were the lungs of the first patient, and there were these kind of nodules. Nodular involvement is more likely to suggest that there is GPA rather than microscopic polyangiitis, and sometimes we do get biopsies from there. But this is one of the autopsy specimens where I'm showing a lung where you have acute lesions and fibrotic lesions. So even on microscopy, we are having an active lesions as well as areas where there is fibrosis. Within an artery, you see this kind of granulomatous glomerulitis. You are seeing these giant cells which are resulting in break in internal elastic lamina. So these kind of granulomatous lesions in the lungs are obviously for GPA, but in microscopic polyangiitis, we may see fresh and old hemorrhages. Generally, you don't see that kind of a granulomatous lesions. So different organs, the pathology there does help us deciding what is the ultimate vasculitis we are going to label. P ANCA, as I mentioned, can be non-specific and be seen with many cases, many inflammatory conditions also. So this one particular case where we were seeing something like crescentic GN, there were these granulomatous vasculitis also, but a lung biopsy was AFB positive. So sometimes it may be very difficult, though. If you see the kidney biopsy of this case, there are granulomatous glomerulitis, there are these kind of granulomas, there are vasculitis. It looks typically like a post-immune crescentic GN, but since the lung biopsy did show presence of AFB positive, those necrotizing lesions, so then everything was diverted towards it being a granulomatous interstitial inflammation in a case of tuberculosis, and it had to be treated like this. Sometimes in necrosis, it is difficult to say whether it's tubercular or not, and we have even taken help of PCR studies to kind of come to the final diagnosis. So some practical points in analysis of ANCA GNR, that rate of ANCA positivity increases with the activity and when the disease is generalized. Anti-GBM may be coexisting in 30% of ANCA diseases, and prognosis is determined by anti-GBM, so it becomes worse. In renal biopsy, presence of interstitial vasculitis in the interstitial artery and different stages of crescents helps it to pick up anti-GBM in a setting of ANCA disease. Renal damage is more with MPO ANCA, and recurrence and activity is more with C ANCA or PR3 ANCA. But in one particular case, it may be difficult to kind of pinpoint whether this is which way this case is going to behave. Light microscopy at the time of biopsy also depends at what time of the course of the disease the biopsy has been taken. A case which is proliferative at one stage may be sclerosing at another stage. These morphological patterns which I see are not specific, but they give us clue. Like if I see proliferation, I think of immune mediated GN. If there's no proliferation, I think of either anti-GBM or ANCA mediated disease. In a case, another case, if patient comes with RPRF and my underlying tuft shows me proliferation along with crescents, there may be a granulomatous glomerulitis also and vasculitis, then that becomes an immune complex mediated crescentic GN. So number of crescents in generally in immune mediated cases are generally quite less. Immunofluorescence will come to our help. It will give us a full house pattern with extraglomerular staining. But even in lupus nephritis, we can have involvement of larger arteries. So I'm just trying to show you that this renal artery in an autopsy had presence of these deposits within a large artery, resulting in these infarcts. This area was positive with immunoglobulins, but no fibrin, no fibrinoid necrosis. So this kind of lesions we label as vasculopathy, not vasculitis, but still they can damage the kidney to the extent that it can cause infarcts. But another case where there is an element of inflammation, there's an element of this kind of aneurysm formation, but this on immunofluorescence is showing me IgG, C3, IgM, and C1q. So this vasculitis is larger artery, is immune mediated. So this we are going to label as necrotizing vasculitis, not vasculopathy, because here I see inflammation. In lupus, in addition to that, you may have only thrombus within the artery. Like these are the MSB stain, it is fibrin. There is no necrosis of the wall, so this becomes thrombotic microangiopathy. So there could be different morphological spectrum which can result in damage within the kidney or any other organ, depending upon what is the site of damage and what all immunofluorescence is there. So even in another example to show you, to emphasize the same point, that IgA disease, which can be crescentic, is an immune-mediated disease. It can have skin purpura, where these vasculitis can show evidence of immunofluorescence. Sometimes this is an example to show cryoglobulins. You have these haline thrombi, which are IgM positive, and EM would show cryoglobulins. So the diagnosis may ultimately come from different type of tests which we do with these tissues. Skin biopsies, as we all know, is an important source for diagnosing vasculitis. So this is one of the cases. This is normal, but here we see this is a case where you are seeing a lot of interjunction pathology and an artery which is showing vasculitis, which on immunofluorescence is confirmed. In addition, you see a band here. So it is a lupus, case of lupus showing vasculitis. So skin biopsy, as we all know, is an important site for picking up various kinds of vasculitis, the immune-mediated vasculitis, or to confirm that it is an ANCA-mediated when it's post-immune. Now coming to medium vessel vasculitis. So here, PAN, as Dr. Rajkiran mentioned, that we are going to see different stages of necrosis. So this part is showing us fibrinoid necrosis, whereas this part is showing us chronic inflammation. So different stages of inflammation involving different segments of same artery is a classical synecdoche of polyarteritis nodosa. It will not have any other immunoglobulins. It will have only fibrinogen, which would be positive. And whenever there is weakness caused by this inflammatory process, the tissues tend to bulge out, resulting in these kind of aneurysm. This is what you see as nodules in cases of polyarteritis nodosa. So break in internal elastic lamina because of inflammatory process pushes it outwards and forming a thrombus here. So this is the same case showing us an aneurysm formation. So so for PAN, you have different stages of arteritis in same segment of artery, and impact of that in different organs could be in the form of infarct, but there would never be a glomerulonephritis in cases of PAN. You may have infarct. Similarly, lungs will never be involved in polyarteritis nodosa. Nerves are one of the common sites of biopsy sent to us. So this is what we tend to look for. We would tend to locate an artery, look for a vasculitis, as you see here. There is fibrinoid necrosis and a healing stage. There's a fibrinoid necrosis of an part of the artery involved, present in this biopsy. And this, now since this is not a visceral artery, but as I said, even medium-sized vasculitis will have smaller vessel involvement. So it will be only after you take into account your ANCA serology, the radiology, and angiography that this will become consistent with something like polyarteritis nodosa. GIT, as I mentioned, very often from emergency we get resected gut, and we will be able to pick up these different stages of arteritis and label it as arteritis, and then call our rheumatology team to come up with a follow-up. So in PAN, you tend to see acute phase, chronic phase, and a healed phase, depending on fibrinoid necrosis, a mixture of inflammation, and only break in internal elastic lamina. So that is what we see in PAN. Kawasaki disease generally.
I think we are exceeding the time.
Shall I proceed or stop here?
Another 2-3 minutes.
You wind up quickly, ma'am.
Yeah, I have just a couple of photographs to show. So in Kawasaki arteritis, we do not see fibrinoid necrosis. It's only the inflammation, and coronaries show us ectasia and changes resulting in infarcts. And this inflammation is never fibrinoid necrosis. It's only lymphomononuclear infiltrate and edema. That kind of a pathology tends to be 68 and T cell rich. Dada, this paper Dr. Rajkiran mentioned, where there's a collaborative work. These are some of the pictures from that, where we saw this kind of fibrinoid necrosis of the skin, and in GI, this kind of aneurysmal dilatation. So there was nothing specific which was seen in these cases. It was only the overall clinical pathological diagnosis which was made after making overall scenario and investigations. Large artery arteritis, this is unfolding of aorta. Here what you see is the EVG gets nibbled off from outside, and here you see a response, granulomatous response to elastic tissue in the form of these giant cells. Impact of this could be in the form of infarcts in different organs, or sometimes complete atrophy, as seen in this one of the nephrectomy sent to us during one of in pediatric case. In giant cell arteritis, again, temporal arteries are sent, where sometimes it may be totally negative, but sometimes only on EVG you may be able to demonstrate a break in internal elastic lamina. Sometimes in large vessel arteritis, adventitial inflammation may have IgG4 rich cells with veno-occlusive changes. Then we are able to label it as IgG4 related aortitis. So that is all I had to kind of demonstrate today in terms of vasculitis present in different organs and how we go about it. Thank you so much.
Thank you, Dr. Dusia, for an excellent exposition. I'm sorry for the technical issues at the beginning. Dr. Amita Agarwal has put a question. Why are the tubules stained on immunofluorescence in ANCA positive vasculitis, that is in post-immune vasculitis?
Tubules stained with tubules will not stain in cases of ANCA vasculitis. It will be only in lupus that will.
No, it's why are tubules stained in IF in the patient with C-ANCA immune GN? I think that's the question.
Yeah, that's
tubular staining will only be seen in immune-mediated GN, not in ANCA-associated GN. In anti you can have tubular staining, but not in post-immune.
The next speaker is Dr. Debashish Danda. He would be speaking on Takashi's arteritis challenges in the management. Debashish doesn't need introduction. He's the immediate past president of the Indian Rheumatology Association, one of the well-known rheumatologists, also the current president of the Asia Pacific APLA. Debashish was the editor of the Indian Rheumatology Association. I think he was one of the main pillars when we started the vasculitis core group in this country. He also started Department of Rheumatology in Christian Medical College, Vellore. Probably made it one of the world-class department. He has struggled very hard to make it. And he has mentored a generation of students and made immense contribution. And he has tried his level best to put India at the top of the league in the Asia Pacific League of Rheumatology countries. And he has presented a lot of papers. Takashi's arteritis is made immense knowledge. Paul Bacon always used to appreciate him, and both of them worked very hard to produce a lot of papers. So I think he doesn't need any more introduction. I would request him.
Respected chairpersons, friends and colleagues, while my screen is being shared, I would like to remember some of the pioneers of our work in Takashi in India. Especially I would like to remember and pay homage to late Professor Paul Bacon and Dr. Shiva Kumar, who were involved in our early days work in Takashi. And I would also like to thank all the colleagues who have been persistently present in Takashi work, like Professor Dr. Mahendranath as one of my mentors in Takashi, Dr. Mishra, my teacher, and Alakindu, friend and colleague. So I'm going to talk the challenges in management of Takashi's arteritis, and I would just try to explore whether the challenges can be actually turned into opportunities. The challenges may be there in diagnostic as well as classification criteria, the imaging features, the disease assessment in terms of extent of disease activity and damage, the biomarkers, and the treatment in terms of immunosuppression, biologics, and interventions. Now, differentials in Takashi is usually not a big challenge, while in the West it is GCA, which is often which ideally speaking should not be confusing, but there are some people who tend to believe that they're part of the same spectrum. I think Dr. Bhaskar Dasgupta will be speaking on it in detail, but I have to discuss little bit about the difficulties of the challenges of differentiating Takashi from GCA in appropriate scenario, although this is not so common in our country. Coarctation of aorta, as you know, Takashi is a reverse coarctation. That's the name it has been given to. And the other differentials are extremely rare. They're often found incidentally while doing imaging. So, as I told, the differentials are not very difficult to be differentiated, but very rarely we may have difficulty in differentiating an earthworm from a snake, and that may be difficult very rarely. So, and both are, one is absolutely benign and other is absolutely toxic, both may look the same. So what are the challenges in classification? Before I go into that, one of the most important thing in diagnosis, why is it important, is as long as early as in 1994, people have identified that the preclinical Takayasu and active inflammatory phase of Takayasu and inflammation plus fibrotic stage of Takayasu has different outcome. So if somebody is intervened at an preclinical stage, which is a pre-pulseless phase, can have a best prognosis. The next is when active inflammation, the next is when there's active as well as there is some fibrotic changes. The next challenge is angiography classification. This particular picture all of us know. This is famously known as Neumann's criteria, some call Harta's classification. While the blue demarcation looks very simple and straightforward for us to differentiate, if you read the original paper where the Neumano describes this type 5, actually type 5 is not as simple as this. He has many cases whom he has labeled as type 5 who actually didn't have so diffuse involvement like this. Some may be even beyond the origin in the branches of the arch of the aorta, and some in the infradiaphragmatic part. So he has called it as a type 5. So type 5 is sort of has been often in wastebasket diagnosis, and because there was no other better explanation, people still classify class 5 this way, and that is why we find class 5 as the commonest type. So you can see, you can have a long segment stenosis, you can have stenosis with aneurysms, and you can have skip lesions, as you can see here, of short segments of disease, and you can have diffuse aortic disease. So because of in spite of these, the classification of Takayasu's and giant cell arteritis have certain mutually exclusive features like the age of onset, extremity claudication, headache, imaging, and histopathology, which differentiated from GCA, younger age. And in spite of this, some people, as I have mentioned, are trying to call both as a part of the same spectrum of disease. But what I'm trying to counter here is Takayasu is not an young onset GCA. If you see even the geographical origin, all of us know that Takayasu is more common in the eastern hemisphere and little more maybe in the Brazil and Mexico and Turkey, whereas most of the GCA come from the northern European ancestry, and it is extremely rare in our population. Also, the female to male ratio is much less prominent in GCA than in Takayasu, and GCA is more, as I have told, more common in the Caucasians than Takayasu in our population. And among all the clinical features also, Dr. Bhaskar Dasgupta will be covering, I'm sure, the polymyalgia features, scalp tenderness, abnormal temporal artery, and visual disturbance are GCA specific, whereas carotidynia, claudication, hypertension, pulse BP discrepancy, bruit and aortic regurgitation are more common in Takayasu's. And if you see the vascular involvement, subdiaphragmatic vessel is more characteristically in Takayasu's, and stenotic lesions related symptoms are more in Takayasu's, and Takayasu is more TNF inhibitor responsive than GCA, which has got more constitutional and cranial symptoms and acute phase response, angiographically long tapered lesions and aortic wall thickening is present in GCA. However, the angiographic differences in the involvement of carotid, subclavian, vertebral, axillary, and abdominal vessels are distinctly different, as you can see here in this picture. Some of the vessels are more commonly affected in GCA than in Takayasu. And because of this, there have been a compilation of the patients from across the world. This include our own patients also, and they have differentiated into 6 different clusters. Cluster 1, 2, and 3. As you can see, the intensity of the color decides the involvement. Are more common in Takayasu, whereas cluster 4, 5, and 6 are more common in GCA. And this is what is the picture showing the cluster 1 which showing the stenosis of the abdominal aorta and renal arteries. The cluster 2 shows the stenosis of the right subclavian artery and the bilateral carotids, and you can see cluster 3 which has got isolated stenosis of the left subclavian artery. And cluster 5 is diffuse vertebral subclavian and abdominal vessel involvement, and cluster 6 is bilateral subclavian and axillary artery disease. So what they found is, I have mentioned 1, 2, 3 are more common in the North American ancestry, and the abdominal disease is symmetric. Isolated left subclavian artery is more common in Takayasu, whereas GCA cluster 6 is more in the North American patients, and bilateral axillary disease and diffuse vascular inflammation without associated damage in GCA. Now this may confuse all of you, but what I am trying to say here is, what they mean is that there is diffuse vascular involvement without any damage, that is without stenosis or aneurysm. So this GCA may have diffuse involvement, but do not have stenotic or aneurysmal feature. Sorry. So, and if you see the histopathology, adventitial fibrosis is more common in Takayasu's compared to GCA, which do not have much of adventitial fibrosis, have mainly media and intima involvement. And microbial connection, as you know, Mycobacterium tuberculosis have been blamed for ages for Takayasu, and Burkholderia has been blamed for GCA. And again, mycobacterial heat shock protein have been thought to be one of the triggers, and vascular remodeling by vascular endothelial growth factor and PDGF seems to be responsible for causing Takayasu's damage. Whereas GCA, there is more associated with the chlamydia pneumonia, and there is no gamma delta T cell and NK cell involvement in GCA, unlike in Takayasu. And even the microbiota is specific. In case of Takayasu's, there is a specific microbiota involvement compared to GCA, which is different. And among the biomarkers, fibroblast growth factor 2 can differentiate Takayasu from GCA, but not between the subtypes of Takayasu. Therefore, it may be a very specific marker to differentiate the two. And here also this the heat map of immunophenotyping shows the CD8 positive T cells. Both the heat map pictures, this on the left side is GCA, right side is Takayasu, and what happens is CD8 positive T cells they keep changing in response to treatment through remission or relapse, and this is more marked in Takayasu than GCA. And historically, HLA studies from beginning have shown predominantly BW52 and IL6 in Takayasu before, and the Jivas ones also have shown, and GCA has got more of DR4 or the class 2 MHC association. So we can see GCA has predominantly class 2 MHC association, whereas the Takayasu is more of class 1 MHC association. And non-HLA genes also are totally different. In GCA it is PTPN22 and FC gamma receptor 2A in Takayasu. And this particular study by meta immunochip strategy shows again that the Takayasu is associated with the class 1 MHC region compared to GCA with class 2 region. So even the treatment outcome, if you see, the Takayasu and GCA have different outcome. Tosalyzumab and steroids benefit clearly in GCA, whereas methotrexate and abatacept have some effect, and TNF inhibitors do not seem to help in GCA, unlike TNF inhibitor help in cases of Takayasu's, and this is the forest plot showing that. So what I am trying to say, that Takayasu and GCA are two different diseases from womb to tomb. Now what are the challenges in assessing disease? Now we have something to feel proud about is the Indian Takayasu's activity score 2010, and with acute phase reactinitis A, it is much more objective and much more doable than the NIH criteria, which requires angiography all the time, which is not feasible in reality to keep doing angiography for patients. Also, our friends from Kolkata has under Dr. Alakandu Ghosh have developed Kolkata color Doppler ultrasonography score as an innovative practical tool, and it has got good correlation with the ITUS A. There are also challenges of appropriate biomarkers. There is no diagnostic markers, and the ESR CRP sometimes do not correlate, and although it may be there in about half the cases, while the high sensitive CRP, ESR, serum amyloid A, C4 binding protein, pentraxin 3, which is a protein similar to CRP, and matrix metalproteinase 9 are useful. Many other the regular CRP may not be many others including regular CRP may not be useful in Takayasu's. And there have been discordance reported by many studies between the vascular pathology and systemic inflammation in Takayasu's in terms of ESR, CRP, and when you correlate with ITAS, patients with improvement or relapse, they seem to be not always correlating. And if you see even for the imaging also, there are some non-progressors versus progressors do not correlate very well with the acute phase reactants. In summary, I'm not giving here the details. We have worked over the last decade or so, and we found, apart from conventional CRP, in our center we found serum amyloid A, MRP 814, and soluble HLA-E as potential biomarkers for Takayasu. IL-6, of course, we have reported long back as it is important useful marker for Takayasu, interferon gamma, and IL-23. The metabolites, like metabolomic study done by Dr. Mishra's group, where we have also collaborated, shows particular metabolite markers. There are also genetic associations of Takayasu, TNF alpha, IL-6, IL-17, IL-23, and IL-18, and angiogenic factors like angiopoietin 1 and CRP polymorphism with blunted response in some patients with CRP. And these are the publications where we have reported this. Now, now I'm coming to the main point of the talk, that is a treatment challenge in Takayasu. Basically, I'm going to talk about the lessons we have learned from the challenges. The challenge one is, how high is high dose steroids? None of us like to give steroids forever to our patients, and more people now do not like to use so much steroids. So we found that the lower initial dose of steroids may be as effective. The Chinese group have shown that 20 to 40 milligram is as effective, and we have found that 0.5 milligram per kilogram body weight as the initial dose has got absolutely same outcome if the initial dose is 1 milligram per kilogram body weight. So there is no need to give the patient unnecessarily high dose of steroids of more than 0.5 milligram per kilogram. The next is the speed of tapering of steroids. We have seen many of our friends and colleagues, some taper it very rapidly, some do it very slowly. So what is the way? So this has been shown by the Japanese colleagues that the slow tapering of steroids is associated with the better relapse-free survival in Takayasu's arthritis. As you can see, that is, it should reduce less than 1.2 milligram per month, and that's how they find by the time the second line agents can take over, you should taper it slowly. Now, steroid alone is the other challenge. Is many people, if you see even in our country and abroad, use steroid alone. It's a very poor treatment option, because every study has shown, including the original NIH study, that moment you taper steroid, the disease bounces back. So steroid plus second line immunosuppressant maintains remission in 3/4 of Takayasu's patient, and this is a very important Japanese study, and they have shown that when you use second line immunosuppressant, the 3/4 of the patients can be maintained patients can be on remission, rather than if they are only on steroids. And this study also shows that the immunosuppression, second line immunosuppression, minimizes the development of new lesions. And this is a Norwegian study where they have shown they have compared their cohort before 1999 with the 2000 and ahead, and the difference is these people had much more of second line immunosuppression. You can see 4% versus 51%, and even TNF inhibitors have been used more often, and you can see that the early versus the late cohort, the damage incidence rate is much lower in the late cohort where the second line immunosuppressants were used. And the new arterial lesions, also if you compare in Takashi during 5 years, they found that if the steroid alone is used compared to conventional DMARDs or immunosuppressants versus the TNF inhibitors, you can see the order of new arterial lesions. Okay, so you have the worst outcome with steroid alone. The DMARDs are midway, and the TNF inhibitors have even better. The same way we can also see after 2 years of therapy, it is much less when we use TNF inhibitors. What about the challenges in intervention? Restenosis is very common in interventions, very common in our center. Dr. George Joseph has done more than 2000 stents, and we have seen his things, and this is the same thing have been published and from another group, and they have shown that immunosuppression improves the outcome of revascularization procedures. You can see glucocorticoid plus immunosuppression versus glucocorticoid alone in terms of cumulative patency rate, which is much better when the second line immunosuppressants are used. Now, next challenge is improving survival. No treatment is worth if the survival do not improve. It's like in hypertension. You control blood pressure, that's not good enough. Is there a survival advantage? So, this is, you can see here, the immunosuppression actually improves survival. This is again the Japanese colleagues have shown the shorter delay in diagnosis, early and moderate dose of glucocorticoids and immunosuppression has lesser complications, and the mortality rate have even dropped down from 4.2% to 0%, and this is because of the higher use of second line immunosuppressants. You can see the 2000 post 2000 cohort versus prior to 2000. The long-term outcome and prognostic factors of complications have also been reported by others, and as I have told that half the patient relapse within 10 years, and unless you have a more aggressive and early treat to target like approach nowadays, we can do using ITAS-A, and we actually have a very high chance of having relapse and complications. And this is the multicentric French series, and they have studied the patients and they have compared and they have seen that moment they have used more of the second line agents, they have found that the overall the 5-year complication free survival has been rising gradually. You can see that with the addition of second line immunosuppressants. And this is our cohort of published 3 years back, our 251 patients long-term follow-up data, and most of our patients are on MMF and steroids, as I told initially, 0.5 mg per kg and tapered off. We had few patients rescue Tosalyzumab, but most of them did not. And you can, what I am trying to impress upon in this picture is that if we modulate the treatment going by the ITAS score, ITAS-A score, and if we escalate and de-escalate treatment depending on the response, overall out of the 251 patients, only 15 patients actually were truly refractory to all treatment. What it means is that you can always have permutation and combination of immunosuppression and monitoring escalation and de-escalation of treatment, and you can control the disease activity in most patients. And if you see here, the same thing is shown here, that the over a follow-up period of, you can see from 3 to 7 months, 8 to 24 months, 25 to 36 months, and up to more than 5 years, you can see that the disease overall we can see the disease activity status and the improvement or the complete as well as partial remission, it varies between 60% to 80%. And if you see the 5-year survival here, which is almost 50%, 10-year survival is about 50%, and 5-year survival is 66%, two-thirds of our patients. So this is not too bad compared to what used to be earlier. And the same thing is being seen now if we compare the NIH series from the Cleveland clinics, the Mayo Clinic, the Turkish series, the Japanese series, the French series, and our own cohort of 602 patient series we have just been published in Oxford Rheumatology. We have actually can see that the centers which have used higher amount of second line immunosuppressants, they have actually the much lower cumulative relapse rate. So the centers which has used less of the second line immunosuppressants have higher relapse rate. Now, what are the challenges? Of course, the biologics are very important in Takayasu's. If you see the mechanisms, postulated mechanisms of Takayasu's, whether it is by HSP65, which actually eventually cause the T helper cells producing TNF alpha, or is it by pathway, presumed pathway 2, where interferon gamma is released and which eventually act and produces IL-6 and Th17. And in the first pathway also both TNF alpha and IL-6 is produced, and the rarely the B cell acting over the CD4 positive cells and again producing TNF alpha and IL-6. What I am trying to say that the Takayasu's, the final end product is often TNF alpha and IL-6 and possibly IL-17 or Th17 pathway also. So we can actually target treatment based on that. While the steroids and second line immunosuppressants are non-specific and they can block broadly all over, we can use anti-TNF in some patients because of the TNF is involved. Because we can use Tosalyzumab with IL-6, and in fact one of the fantastic ways of controlling disease activity and steroid sparing, quick acting. We have Ustekinumab, which can be used. We don't have the access to it yet, and possibly because of a Th17 pathway. And some people suggest even rituximab may be involved because there are some reports of anti-aorta antibodies in Takayasu. So TNF inhibitor studies have shown overall that TNF inhibitors actually can benefit almost 2/3 of patients, whereas 1/3 can have relapse. And this study on Tosalyzumab, the study design, because of study design and the number of patients, it did not achieve the primary endpoint. However, the time to relapse was much lower when Tosalyzumab was used, and that's clinically meaningful. While Abatacept was found useful in GCA to some extent, in Takayasu it was found to be not useful. And this is systematic review of Tosalyzumab and Abatacept. Well, Abatacept absolutely clearly it's not beneficial. Tosalyzumab, it was borderline significance. That's because of the smaller studies and smaller number of patients and a lesser number of well-designed RCTs. And again, when we compared the synthetic DMARDs with biological therapy, we found that the biologic therapies are superior to synthetic DMARDs. And interestingly, some people have also reported there is no difference between anti-TNF and Tosalyzumab, although we use less often anti-TNF because of risk of tuberculosis reactivation. So overall, the message is treat Takayasu for better treatment outcome and survival. We cannot wait like swan neck deformity for rheumatoid to be treated, or bamboo spine for Angstbon to be treated, or parotid enlargement for Sjogren's to be treated. We cannot wait for somebody is absolutely pulseless and then you treat. So it is an ongoing inflammation. And what has happened because of the aggressive immunosuppression? You can see 20 years back the Japan and China had mortality between 10 and 16%, and now overall the mortality all over the world has dropped down between 0 to 4%. So Takayasu outcome has improved. So what is the take home message? Angiography is the gold standard. It needs amendment in classification. I have mentioned to you the difficulties of the Numanos classification. The clinical classification also is evolving, and hopefully this will be more meaningful than this, and we need better tools for assessing. But at the moment, ITAS 210 and ITAS A are very useful and probably the best. We need better biomarkers, although we have evolved a few. We need more, and we need more aggressive immunosuppression for better outcome. That is very, very important, and timely intervention helps. And remember, intervention has to be done when the immunosuppression has controlled the inflammation, otherwise the outcome is disastrous. So what I have told, ladies and gentlemen, is the challenges of managing Takashi can actually become opportunities, because these difficulties has taught us many things over the last decade or so. Thank you very much.
Thank you, Debashish, for the excellent talk. Take few questions.
Best imaging, Dr. Lalit Duggal, best imaging modality for diagnosis and best imaging for follow-up. Well, some people claim that the PET-CT is good for the initial diagnosis. In our experience, and several studies have shown, including the systematic review, which showed that the PET may be having moderate value in initial diagnosis. Because of the contrast, may be contraindicated in some cases. MR angio is becoming more and more popular. However, whenever the intervention is needed, conventional and DSA digital subtraction angiography are still being used, and CT angio with 3D reconstruction is an excellent picture it gives, except that it has contrast. But I would like to say that what Dr. Alakandhu has done, those ultrasound Doppler images, and now ultrasound Doppler with contrast has come, which is very, very interesting. The Doppler with contrast is supposed to be semi-invasive and supposed to be very, very useful. So we do not have a clear answer to all that. If you ask me what we use in our center, we have also changed over the years, and we use mostly MR angio these days. Some patient will use CT angio 3D reconstruction. And for follow-up, PET-CT is not a good option in our experience. Somebody asked about role of anticoagulation and aspirin in CVA. Well, anticoagulation is, I would not recommend straight away. In fact, one of the causes of Takashi early mortalities have been because of anticoagulations. Whereas antiplatelets are important. Takashi, because of endothelial pathology, there is platelet aggregation, etc. And most of the time antiplatelets are used. Unless the patients of Takashi has antiphospholipid antibodies, which is present in about 10 to 15% patients sometimes, we may use anticoagulation cautiously, otherwise risk of intracranial hemorrhage is high. Our intervention cardiologist Dr. George Joseph uses double antiplatelets after a procedure for about 6 months, and then switches back to single antiplatelet.
Thank you.
Thank you. Thank you.
Is Dr. Vasculitides Gupta, Professor and Head of the Department of Rheumatology at Southern Hospital, UK. He's going to speak on giant cell arteritis, cranial versus large vessel disease, current concepts. Dr. Das Gupta is of international repute when it comes to polymyalgia rheumatica and giant cell arteritis. Giant cell arteritis, which needs a multimodal assessment approach for diagnosis, because temporal artery biopsy has about 70% sensitivity. Dr. Das Gupta has been doing ultrasound for temporal artery arteritis, giant cell arteritis, for more than 20 years, and he has been an investigator for development of ULAR ACR classification criteria for PMR and GCA. So, Dr. Vasculitides Gupta, please.
Yojana, you might also add, Bhaskar has trained the maximum number of Indian rheumatology trainees in United Kingdom, and is a multi-talented fellow. He's a singer and an instrumentalist and a fantastic host.
Thank you very much. I would like to thank the organizers for inviting me to talk to you about cranial versus large vessel giant cell arteritis. And these are my disclosures. And so to start with, I'm going to include polymyalgia rheumatica in it because GCA and PMR are conditions that overlap. And the traditional GCA focuses on cranial symptoms, whereas the subject of today's talk is to differentiate cranial GCA from extracranial GCA, which primarily presents with polymyalgia, constitutional symptoms, and limb claudication. Which can coincide with cranial GCA, occurs often as an independent clinical subset, which we label as large vessel GCA or overlap with PMR. And also, we will refer to the fact that imaging studies have shown that up to a third of patients with PMR may have subclinical large vessel inflammation at disease onset. So to start with, in terms of the pathogenesis, what we see here in the first instance is, let me change it. In the first instance, an uninflamed arterial wall. You can see the adventitia, the media, and the intima. So in the first instance in GCA, you get the activation of dendritic cells, you get the activation of T cells which recognize a putative unknown antigen, and through the help from co-stimulatory molecules. And that's when the immune process starts. And then you have the Th1 and Th17 response. You get the macrophage activation, and that gives rise to a lot of the inflammatory changes and inflammatory symptoms that we see in GCA. And finally, you get the macrophages not only causing inflammation, but also relate to damage and remodeling. So the vasodestructive element of GCA then occurs, and you get this very important and almost individual feature of GCA, this remarkable intimal hyperplasia that is responsible for the very devastating ischemic complications. So in terms of what happens in GCA, both cranial and large vessel, so you get the vessel wall inflammation as I showed you earlier, and this gives rise to compromise of the circulation through the intimal hyperplasia and narrowing of the lumen, and also then you get the ischemia. In terms of ischemia, you get the headache, which is an acute onset severe headache. You get the scalp tenderness, which in my experience is primarily due to ischemia. You get the tenderness in the scalp, and if you don't relieve it, you get actually scalp necrosis. You get the jaw claudication, which is really due to the ischemia of the masseteric muscles and the dreaded visual symptoms, which, if not treated early, gives rise to the visual permanent ischemic complications of sight loss. And of course, you can get the different arteries that can be involved primarily in the upper limbs, giving rise to upper limb claudication. In terms of symptoms which are more generalized, you get tiredness, weight loss, you get fever and night sweats. And this is one of the features, predominant features of giant cell arteritis, these drenching sweats which you can get at night, during the day, and low-grade temperature, and you get the weight loss. And of course, you get polymyalgia. And these symptoms are the inflammatory symptoms primarily related to the Th17 pathway. And again, related to that, you get blood tests showing sustained rise in inflammatory markers and thrombocytosis and anemia. When you examine these patients, you get a temporal artery thickening, tenderness, pulselessness, and when this predominates with the cranial symptoms, you get what's called cranial GCA. but also you can get a more diffuse, disseminated disease where you get blood pressure differences in the upper limbs, you get bruits, and GCA is one area where you must auscultate the axillary artery. So you particularly get the bruits in the axillary artery. Dr. Danda was talking about the carotids being less involved, which is probably not that true, because quite frequently we get carotidynia, and I have a feeling that a lot of the neck pain that we see in GCA is actually due to involvement of the carotids. And of course, the vertebral arteries are particularly involved in GCA. And you get the pulselessness of the limbs. And this is what we call the large vessel GCA versus the cranial GCA. So, in terms of the new concepts that I'm going to be talking about today, is essentially we need to be looking at a more expanded target population. We need to be talking about fast track clinics. GCA is the one rheumatological condition which is a critical ischemic disease and should be treated on par with myocardial ischemia, treated on par with cerebrovascular ischemia. So it needs fast track clinics. It needs hyperacute treatment. I shall talk to you about the probability score that we have actually done a lot on to try and triage the referrals to these fast track clinics. I shall talk to you about disease stratification based on severity, based on extent, based on damage, and of course refractory versus relapsing disease. And how do we diagnose and monitor GCA? And I know there was this big question at the end of Dr. Danda's talk, and I would like to put to the attendees here that ultrasound and trained sonographers are the key. I think they are the key to assessing GCA, and they probably might be the key to assessing other forms of large vessel vasculitis, such as Takayasu's. And of course, PET-CT is something that we do regularly, but we are constrained by its expense, constrained by the radiation. And finally, I'll talk to you about the treatment. Certainly, we'll talk about biologics and trials. I may not have the time to go through all the trials, but I shall certainly mention some of the very interesting trials that are going on, sadly, which have been paused due to COVID. And of course, we are very excited in terms of conventional DMARDs by leflunomide. And I would suggest to the Takayasu's community that they should take a very serious interest in the, the effectiveness of leflunomide in Takayasu's. So, the target population. The target population is really an overlap. And here we have cranial GCA, and then we have polymyalgia rheumatica, which is basically a proximal pain and stiffness syndrome, which affects the shoulder girdle and the hip girdle. And then we have large vessel vasculitis. And all these disease entities, they overlap and in many ways form a continuum of disease. And what we have realized is actually from the imaging, here you can see that the same patient may have on ultrasound involvement of the temporal arteries. The same patient may have polymyalgia, and here you can see the tenosynovitis of the bicipital tendon. And the same patient, when you do a PET-CT, you can actually see the uptake in the subclavians, the carotids, and the axillary arteries. So what we would suggest is that the original ACR 1990 criteria need to be expanded. So the age of disease onset can be kept at 50 on both sides, although primarily in GCA we see age above 65. The average age is about 70 to 72. Instead of just having new onset headache, we should add in the symptoms new onset headache plus visual symptoms. Polymyalgia rheumatica constitutional symptoms, and jaw-tongue claudication. Instead of just having abnormality of the temporal artery, we need to be talking about abnormality of the temporal and other extracranial arteries. Instead of just talking about the ESR being elevated, we need to be talking not only about the ESR, but the CRP, which in my hands actually appears to be more specific and in terms of interpretation of disease activity. Instead of just talking about temporal artery biopsy, we need to be talking about not only biopsy, but other forms of imaging, such as ultrasound, such as MRI, FDG, PET, etc. I'll start with a case study and really how a patient can morph from one form of disease to another. So this is a 76-year-old lady who in 2014 presented with headaches. She had a temporal artery biopsy, and the temporal artery biopsy was positive. And she was treated successfully. She came off steroids 2 years later, but in another 5 months, she started developing night sweats and other constitutional symptoms. In February 2017, she developed headaches and polymyalgia, and the CRP was elevated. And when we did the ultrasound in the clinic, here you can see the classic features of large vessel GCA. And here, this is an axillary artery ultrasound. And here you can see the thickening of the intimal medial complex. And that's more than 1 millimeter. And in fact, with the addition of atheroma, in fact, it becomes much thicker. And so this patient underwent a FDG PET as well, which showed that she had started with cranial GCA, developed polymyalgia, and then developed large vessel GCA. So what are the differences between cranial GCA and large vessel GCA? Cranial GCA by definition involves the cranial arteries, whereas the large vessel GCA primarily involves the aorta. And I'll show you it primarily involves the supradiaphragmatic blood vessels and the branches from the arch of the aorta, such as the brachiocephalic, such as the subclavian, such as the axillary, but also the carotids and the vertebral arteries can all be involved in large vessel GCA. So the differences in terms of large vessel GCA versus cranial GCA. So large vessel GCA, about a half of them are actually negative on temporal artery biopsies, naturally, because the disease is not occurring in the temporal arteries. Nevertheless, considerable number do have cranial symptoms, and a lot of large vessel GCA would not fulfill the 1990 ACR criteria. The visual symptoms are relatively infrequent, and the mean age is younger than cranial GCA, although older than the Takashis. I do feel that there may be some degree of overlap. I understand some of the details of Dr. Danda's talk. And just like with Takashis, we have a diagnostic delay. And although cranial GCA is an acute disease, large vessel GCA tends to be a more subacute disease leading to diagnostic delay. In terms of diagnosis, fairly straightforward. Cranial GCA traditionally is diagnosed by temporal artery biopsy, in large parts of the world. But in fact, if you have good temporal artery ultrasound equipment, probes, and a trained sonographer, the temporal artery ultrasound is far, far better because it can examine the entire temporal artery on both sides, its branches, but also the axillary artery. Large vessel GCA involving the aorta and its branches, we can diagnose based on axillary artery ultrasound, and most of the large vessel aortitis is usually associated with axillary artery involvement as well. But of course, we use a lot of PET-CT, CTA, MRA as well. So in terms of the overlap, you see this overlap between cranial, large vessel GCA, and PMR, and there are specific problems. So we see sight loss as a big problem in the cranial disease. we see large vessel GCA as a frequent relapsing disease. So essentially, even by definition, large vessel GCA tends to be of a poorer prognosis compared to cranial disease. And of course, we see that there is delay in disease diagnosis because of its subacute nature. And that leads often to large vessel complications. And we'll talk about aneurysms, stenosis, dissection. All of that can occur in patients with large vessel GCA. And because of their more indolent, long period of disease, they tend to have higher glucocorticoid requirement, and they tend to have a greater amount of glucocorticoid-related complications, such as osteoporotic fractures, such as diabetes, such as myopathy, etc., etc. So really, large vessel GCA is a treatment major target for people who deal with GCA. We can pick up large vessel GCA very nicely when our radiologists do scans. Quite often, if you're faced with a patient who is losing weight, who's got high inflammatory markers, and who's got anemia, the first thing that clinicians do is a CT scan of the chest, abdomen, pelvis. And in fact, our radiologists where I work, they not only look for infection, they not only look for cancer, but they look for aortitis. And we get quite a lot of de novo LVGCA referrals directly from the radiologists who have looked at a CT scan of the chest, abdomen, pelvis, and they've found that there's soft tissue thickening around the aorta, and that prompts further investigations. But of course, our bread and butter is ultrasound. And I actually can't think of a proper specialist large vessel service without ultrasound in the clinic. So in the axillary artery, if you do ultrasound in patient with large vessel GCA, you see this striking intimal medial thickening, and it can't be missed. And the big advantage is this is a clinic side bedside procedure and takes literally 5 minutes to do. This is the normal axillary artery with the normal intimal medial complex, and we nowadays do the ultrasound without the color Doppler, but if you did the color Doppler, that's a completely normal axillary artery. In a patient with axillary arteritis as part of large vessel GCA, you can see that there is thickening of the intimal medial complex. And that's on the longitudinal view, and that's on the transverse view, and it's striking. And so you make your diagnosis very, very quickly if you have access to ultrasonography. When you do FDG PET in these patients, you can see that they have the aortitis. Although in this patient, you can see the abdominal aorta being involved, but essentially a large vessel GCA is primarily a supradiaphragmatic disease, and it quite often involves the axillary arteries as well. And here you can see the particular involvement of the descending aorta and the aortic arch. And I draw your attention to the ascending aorta because this is where damage starts. So now we have evidence from follow-up of patients with large vessel GCA. This is the first area which starts dilating and where we start seeing aneurysms occurring. So I'll talk to you a little bit about the fast-track pathway, and it's very important that we have a fast-track pathway for GCA because GCA is a critically ischemic disease, and the sight loss in GCA is what I term a stroke in the eye. And this is irreversible. And the most important thing is that the sight loss in GCA almost always occurs after steroid therapy. So these ischemic complications are preventable. So you need to have a hyperacute treatment for these patients. And so you need a speedy referral to the specialist, secure and timely confirmation of the diagnosis, and a prompt start of treatment. So we have the fast track clinic, and the criteria are generally people above 65. They have to have symptoms of GCA, which we have talked about already. Generally, we like to see acute or subacute onset, so less than 6 weeks or less than 12 weeks, and they must have raised inflammatory markers, CRP or ESR. And these patients are referred to the fast track clinic. We tell all our GPs and other clinicians that if they have visual symptoms, they must start these patients on steroids before they're seen in the fast track clinic. And by visual symptoms, I talk about amaurosis fugax, which is an intermittent sight loss, and diplopia. And these symptoms are frightening prodromal symptoms of an impending permanent sight loss. And these patients need to go on to 60 milligram prednisolone and also have an ophthalmology referral. All the other patients, they get 40 milligram prednisolone started before they're seen in our clinic. And we tend to see them within a day and often within a few hours. And the aim of the fast track clinic is to do temporal artery ultrasound, do a clinical assessment. We sometimes do temporal artery biopsies, although numbers have really dropped. And we can provide a secure diagnosis to as many patients as possible. And we have reduced sight loss and strokes in GCA. But most importantly, we get a quick diagnosis so we can minimize the use of inappropriate prednisolone, because we exclude all the GCA mimics in the fast track clinic. And so we prevent a lot of steroid-related morbidity. And the paper, the seminal paper on the fast track clinic in GCA is headed, as Dr. Mahendranath said, I've had the great fortune of working with lots of Indian colleagues. And this is Dr. Patel, who trained in the UK and who is now a rheumatologist in Pune. And so this is the seminal paper on the fast track pathway, which reduces sight loss in giant cell arteritis. And quite dramatically, it cut down sight loss in GCA by less than a third. And we could diagnose these patients much sooner. And also, the most important thing is that actually is cheaper. So because it's such a simple pathway, so patients are referred to a particular specialist clinic, and therefore they don't have unnecessary investigations, because GCA manifestation can be quite protein, and it results in a significant cost saving. I shall talk to you a little bit about the Southend probability score, which we have developed to try and triage these patients. And this is based on giving weightage to demographics. So as you get older, you get higher scores. It based on the gender. So women get higher score compared to men. It's based on duration, and certainly patients who have symptoms more than 24 weeks, they get a score of 0, and patients who have less than 6 weeks, they get a score of 3. It's based on CRP levels. 0 for less than 5, 6 to 10 is 1, 11 to 25 is 2, and more than 25 is 3. They also get scoring based on their symptoms. As you can see, headache scores very little because it's the most non-specific symptom, but you get more scoring for polymyalgia, constitutional symptoms, ischemic symptoms, and of course you score highly if you have ischemic visual deficits, temporal artery abnormalities, extracranial abnormalities, and cranial nerve palsies. One important point to make is that upper cranial nerve palsies, 3rd, 4th, 6th, are something that we frequently see as an ischemic complication of GCA. And this is an innovation, I think, in terms of probability scores. We give a negative score if you have alternative diagnosis, such as infection, such as cancer, such as systemic rheumatological diseases, such as other head and neck pathology. So using this probability score, score. If they have a score less than 9, we say it's low probability, and 9 to 12 is intermediate, and more than 12 is high. We tend not to see the low probability patients. We tend to see the intermediate and high probability patients. And these patients, we have worked out an algorithm where these patients are given an ultrasound. And for example, low probability patients, if the ultrasound's negative, we discharge these patients, look for an alternative diagnosis. If patients have a high probability, ultrasound is positive, we treat as GCA. All the others, the intermediate group, or if the ultrasound by some chance in the low probability group is positive, or high probability group is negative, these patients will have additional tests. So in the fast track clinic, we come out with 4 diagnostic categories. GCA is unlikely, or GCA is likely, where you treat as GCA, or GCA is uncertain, or where GCA may need treatment as GCA, but you're doing additional tests. So, and I think that this is an approach that can be applied to many other diseases, rheumatological and non-rheumatological, in terms of, judging their symptoms, triaging based on probability score, and making a diagnosis. And we have published this a couple of months ago, and really this is our fast track clinic. In a nutshell, so you make a diagnosis, you take the history, you look at the blood test, you look at the signs, you make a judgment on the probability score, you do an ultrasound scan, and then you can come whether it's GCA is likely or unlikely. Or you may have additional 2 categories where you might need to do additional tests to make the diagnosis of GCA. And this is a modality, this is an approach that can be followed in other diseases as well. So, of course, temporal artery ultrasound is vital to our GCA service. And we look at the common temporal, the parietal, and the frontal branches. And this is the characteristic halo that you get in the temporal artery when you do ultrasound. And this is due to the wall swelling due to inflammation in the blood vessel. And you can also do ultrasound of the axillary artery, and here you can see the thickening of the intimal medial complex in these patients. And the most pathognomonic sign of GCA is the compression sign. So the compression sign is that when you see a halo, you try and compress the blood vessel. And if the halo is artifactual, on compression of the blood vessel, the halo disappears. If the halo is actually due to GCA, when you compress it, it still remains. And this is the pathognomonic sign of GCA. We have now published that, and I would recommend this to my colleagues in India who see lots of Takashis, that quantitative ultrasound can be used in the follow-up and assessment of these patients. And when I talk about quantitative ultrasound, we talk about actually looking at the 6 temporal artery segments, common temporal, parietal, frontal, and the 2 axillary, and we grade the halo thickness from 0 to 4 in each segment, and then we can come up with an ultrasonographic halo score, which we published last year in the ARD. I know that there is correspondence from Calcutta, from Alakendu Ghosh and his colleagues, that similar score can be used with the addition of subclavian in the assessment of Takashis disease as well. And we have shown that the ultrasound score, halo score, picks up people with high risk of ocular complications, correlates positively with inflammatory response, and predicts an unfavorable disease outcome at 3 years, and has actually now we have shown a good diagnostic accuracy for the diagnosis of GCA. And we have also shown that the halo score correlates with pathology. We heard a talk from a pathologist today, and we have shown that if you do temporal artery biopsies in these patients, the patients who have the largest halo scores are the patients who have intimal hyperplasia. And we are now using the ultrasound to also monitor for damage, aneurysm, stenosis, dissection, and I'll just show you a couple of case examples. This is a lady who presented with relapsing PMR and was having lots of steroid side effects and had quite active PMR type of symptoms. We did ultrasound of a temporal artery, and this shows changes of typical GCA. So this is what I call polymyalgia arteritica. This is a typical feature of large vessel GCA, and here you can see the axillary artery is also involved in this patient with the halo. And we did FDG PET scan, and she just lighted up like a Christmas tree. And you can see the involvement of the brachial cephalic, the subclavian, and the axillary vessels. And more importantly, you can see that this lady was already getting damage. So there's dilatation of the ascending aorta, and you can see that the wall of the ascending aorta is still inflamed. So there's aortitis associated with dilatation. So this is damage to the large vessels in a patient with clinically relapsing PMR. And we treated her with Tosalyzumab. Another patient, and we have seen several patients with aortic dissection associated with aortitis, presented with severe back pain and chest pain, breathlessness, constitutional symptoms. And here you can see that in the aortic arch, the soft tissue, this is a typical picture of aortitis, and the patient also had an aortic dissection and responded very well to Tosalyzumab. Talking about the distribution of vascular disease in large vessel GCA, unlike Takayasu's, we think it is a supradiaphragmatic disease. And primarily, we see involvement of the descending aorta, the arch of the aorta, and also the brachiocephalic, the carotids, subclavian, and the axillary arteries. And that's why axillary artery ultrasound is so accurate in this condition. And the symptomatology for large vessel GCA, these patients generally have constitutional symptoms, polymyalgic symptoms, and a small minority will also have cranial symptoms. Very important, Dr. Danda talked about that when we give steroids to monitor for steroid side effects, and we certainly have gone away from high doses of steroids, but for initial phase, and we monitor these patients, and certainly all of them get down to 5 milligram or less, so that the benefit exceeds the risk of harm. And we are now increasingly using leflunomide in our patients. Certainly, we have published a couple of case series, and we have just have a paper awaiting publication this month looking at large vessel GCA and the effect of leflunomide. And that certainly has been very, very positive. I'll quickly go on to Tosalyzumab. Tosalyzumab mainly really works on IL-6 receptor, so it's the Th17 arm versus the Th1 arm that both of these arms are affected in GCA. Many years ago, in 1988, I was the first to describe elevated interleukin-6. This is the first report of IL-6 elevation in any form of vasculitis in patients with GCA and PMR, and that was corroborated by other studies which showed presence of IL-6 in the temporal artery segments. And we used Tosalyzumab in terms of giant cell arteritis and large vessel vasculitis. This is a paper that we published in 2016 showing long-term efficacy and safety. And in these patients, we found that tocilizumab does work, but the problem with tocilizumab is that when you stop the tocilizumab, the treatment tends to rebound. And this was experienced with monthly IV tocilizumab. And very interestingly, in the paper, we described what we call medical revascularization. So these patients actually with large vessel GCA, tocilizumab caused, in fact, the pulses to return, and the ultrasound shows, in fact, that recanalization of the artery. So the Gca study, I won't go into great details. Most people know this is looking at tocilizumab versus a placebo, which is essentially steroid tapered off within 6 months or 12 months, and tocilizumab both weekly or twice weekly showed a huge difference between steroids alone. And this has led to the approval of tocilizumab for GCA, and it reduces the steroid burden significantly. If you use tocilizumab, you can cut down the steroid burden by half. And we now are using it primarily in relapsing disease and refractory disease, and also people who really are getting lots of adverse events from steroids. And generally, we tend to use it if they don't succeed with the use of leflunomide. And that is the group of patients that we are using tocilizumab. We have published last month our paper on the efficacy and safety of tocilizumab in GCA and using imaging, and we found it to be very effective. Certainly in 90% of patients it gave us remission, although not every patient was able to continue it in a continuous way. Some patients had to discontinue because of side effects, and some patients had to have interruption because of side effects. But the outcome was excellent. So we are very pleased about the safety and efficacy of tocilizumab, and this is real-life experience. We showed that the steroid doses drop dramatically with the use of tocilizumab. We've also done ultrasound of the temporal arteries, and we can show that the halo thickness decreases quite rapidly when you use tocilizumab, and also the intimal medial complex in the axillary arteries decreases. We've done PET scans in these patients, and using the total vascular score, we can show, in fact, the PET scan also shows decrease while we use tocilizumab in patients with large vessel GCA. So overall, we think tocilizumab is efficacious and safe in relapsing refractory ischemic GCA. We have now started using intravenous single infusion of tocilizumab in patients presenting with ischemic ophthalmic symptoms. And this is something that we are writing up, and we are very excited that a single intravenous infusion of tocilizumab, a bit similar to what people are now using it in COVID, this may be an option in limiting hyperacute evolving visual symptoms. Infections and other adverse events do occur, but overall safety is good, and ultrasound is excellent in identifying patients and monitoring disease. I won't go into the details of these other trials. Now, the Cerakobab study, which is also an anti-IL-6, has been published, and it works, but the company withdrew the trial because of business reasons. Other medications that have been tried, Cerakobab, again, Cerakobab in polymyalgia rheumatica and in GCA. And of course, we know that Cerakobab is also being looked at in COVID. But sadly, COVID has paused this trial. Abatacept, Dr. Danda already talked to abatacept, that it works in GCA, and we are planning to do a phase 3 trial as soon as COVID is controlled. We also Dr. Danda mentioned the ustekinumab, and there are controversial differing results from GCA studies, and this needs a proper RCT in GCA. We've got other trials, including the use of secukinumab, and secukinumab trial has been paused because of COVID, the Titan study, and again, this shows promise as a treatment in GCA. Mavrelumab, this is an anti-GM-CSF. This probably is the most promising biologic in GCA. Luckily, the phase 2 study concluded before the start of COVID and showed excellent results. Patients in the Kinexa study showed a significant reduction in the time to first flare in the mavrelumab group compared to the placebo group, and higher sustained remission. And we really look forward to a phase 3 study. And of course, the JAK inhibitors, whether it be baricitinib and upadacitinib, and all these small molecules may show great promise. And this is a study which I'm the chief investigator for. Sadly, we have had to pause this because of COVID. But again, when COVID gets control, this is the most exciting small molecule that we look forward to using in patients with GCA. So the future is very promising to try and limit systemic inflammation, ischemic complications, large vessel vasculitis, and PMR symptoms using these new biologic agents. Finally, I would like to acknowledge all my research fellows. As Dr. Mahendranath mentioned, we've had the great privilege of lots of Indian doctors and trainees working with us, and Sivalik Banerjee, Parashar Ghosh, Sumit Agarwal, Dr. Davanand, Anurag Bharadwaj, Dr. Balakrishnan, Shubhada Khalke, and of course Saqib came from Pakistan, from Islamabad. And so we have really offered training to a lot of people from the Indian subcontinent. And many of these doctors have gone back and are very distinguished rheumatologists in India. So, and also my acknowledgement to other organizations, BSR, ACR, ULR, and my colleagues internationally, and also the PMR GCA UK charity, and also all the NHS England resources who have helped with all the studies that I've done over the long years. Thank you very much.
Thank you, Bhaskar.
So much, Dr. Dasgupta. Excellent talk, very informative. There are multiple questions about, is there coronary artery involvement, and how frequently pulmonary arteries are involved in giant cell arteritis?
That's a very interesting question. And so one important point that I made is that the most important area of the large vessel that first gets involved in GCA is the ascending aorta. So in patients who have ascending aortic dilatation, we frequently, these patients often get other coronary artery disease. So it's something that we look for very carefully. Time prevented me from going into the details of the monitoring. Echocardiography is a very, very important monitoring for patients with GCA, particularly patients who have relapsing disease, who have ascending aortic involvement, who have large vessel disease. We don't see so much of pulmonary artery involvement. So I think that's a difference between Takashis. We definitely don't see pulmonary artery aneurysms or any other forms of involvement. We do see thromboembolic complications occurring in GCA as well.
Your take on JAK inhibitors in management of GCA?
Yeah. I think theoretically, JAK inhibitors are very, very promising. I certainly am looking forward to the AbbVie study looking at upadacitinib in giant cell arteritis. We were ready to roll, and we had got all the centers, sadly. So by this time, we should have been halfway through the recruitment for upadacitinib. Sadly, COVID came and stopped all non-COVID research. So as soon as we get control, we are planning to restart the upadacitinib trial. And certainly, one important thing that I would like to mention to you, that we have found association between spondyloarthritis and large vessel vasculitis. We all know that the aortic root is dilated in spondyloarthritis, but we have not asked the question why it is. Is it so? And my answer is that many of patients with spondyloarthritis, with raised inflammatory markers, who don't have inflammatory bowel disease, who don't have peripheral arthritis, but who have large vessel vasculitis, and these patients, I think, would respond very well to small molecules like JAK inhibitors. Yes, so that's a very promising area.
Yojana, being the co-moderator with you, can I have the privilege of asking a question?
Sure.
Bhaskar,
Yep.
do you think we have much PMR in this country, in India, or we are simply not looking for it, or we are ignoring it?
I am sure you have it. I have seen patients with PMR in India. I think the problem is that you have so many other rheumatological conditions that sometimes PMR may be missed in that group of patients. But, it may not be that common as we see in the West. But I have actually seen patients with PMR in India. And I know several rheumatologists from India have told me that they have seen patients. Praveen, who worked with me in Southend for so many years, Praveen Patel, he tells me that he sees PMR in Pune.
When to start Tosalyzumab in GCA along with glucocorticoids or only in refractory cases? You do start upfront Tosalyzumab.
Sadly, we are not able to start tocilizumab up front in all patients with GCA. We don't get the funding for it. NICE has approved it only for refractory relapsing disease. But we can start it in patients with predominant ischemic complications. I'm using a single IV infusion of tocilizumab in these patients. But we tend to use it in patients who have relapses. So you control them with high dose of steroids, you bring the steroids down, and they start relapsing. We tend to use it in large vessel GCA, so patients who have raised axillary artery IMTs, who have got positive PET-CT. We tend to use it in patients who fail leflunomide or methotrexate. We don't, all these patients, we tend to use tocilizumab, but we can't use it in all patients.
One question from my side. Do you see them as just fever, prolonged fever, PO-like presentation?
Yeah.
Because I remember seeing two of such patients. Large vessel vasculitis only presentation was PO, and a PET done, showed uptake in the aorta, and then after starting treatment for aortitis, the way we start treating large vessel vasculitis, they responded. Only presentation was PO.
Absolutely. So, in fact, we get, there are three groups of patients where we get large vessel GCA. One is patients with cranial GCA who go on to develop large vessel GCA. One is the group of PMR patients who actually turn out to be large vessel GCA. The third group, the de novo group, is the group that you refer to, patients who get admitted under the physician's non-rheumatologists with constitutional symptoms, with PUO, and then as part of the investigation, they have a CT scan of the chest, abdomen, and pelvis, and the radiologist reports the aortitis. So almost all these patients actually in our hospital will get referred to me for an axillary artery ultrasound, and thickening of the intimal medial complex will be a feature of large vessel GCA.
Dr. Aman Sharma has one question. If I may say, do we have PMR or even large vessel GCA or even large vessel, sorry, twice he has typed the same thing.
Yeah, so Dr. Aman Sharma, without breaking confidentiality, in fact, when I was talking about my having seen patients with PMR in India, I was thinking about Dr. Aman Sharma's patient. PMR exists in India. I'm pretty sure if you look for it, it definitely exists. I have seen GCA also ultrasound positive, but I suspect that you don't see as much GCA in India as we see in the UK. I don't know whether the age, the survival is different. We tend to see really the very elderly patients in the plus 80s. But I mean, India, you must have many patients like that. So I don't know whether these patients get funneled off to the neurologists if they have headaches, whether there's a referral bias there.
Ophthalmologists, we need to create actually more awareness amongst ophthalmologists.
Yeah. So, I would put to you that I think it'd be great if the Indian Rheumatology Association takes up a program, particularly with this major interest in large vessel vasculitis, to get your young trainees all trained in ultrasound. And I think that's, my personal opinion is that you can't actually treat large vessel vasculitis in an adequate way unless you have access to vascular ultrasound, because it's like the ophthalmoscope, it's like the slit lamp for the ophthalmologist, so we do vascular ultrasound for almost every patient that comes to our clinic at each attendance.
So thank you very much. Thank you very much for the wonderful sessions we had. Special thanks to Mahendranath and Jojana for conducting this session. We had a fantastic speakers. On the one hand, Vasco Dasgupta as a GCA man and Devashish Danda from our side as a Takayasu man. And we had a really very great interactive sessions. Raj Kiran initiated, though young in age, but really very full of wisdom, and he put a lot of insights. And as usual, Ritambara gave us great insights and support to the clinician in reference to what's happening inside. So it was really a great session. Thanks to all of you for contributing and enriching us. We have tomorrow another very exciting session, second phase of vasculitis. All of you must join. Interestingly, in the last week, we had a great session with Bangladesh on vasculitis, and Bhaskar was there, Devashish, myself, and interestingly, it was in Bengali, and all the slides were in English, signs were there, and interactions other were in Bengali. It's a fascinating, really, we all enjoyed. So along with us, we had Obro and Sujata. So very nice. So thanks to all of you. Interestingly, we are simultaneously continuing sessions for the young trainees as well. In the next week, we have this last part of the sessions. So all of you are welcome. Have a wonderful weekend. Thanks to all of you. Thank you very much.